I'm Dr. Lisa Fitzpatrick.
And I'm Dr. David Malebranche.
So, David, you know I'm Dr. Lisa on the street, right?
I am well aware that you are Dr. Lisa on the street.
So, during the pandemic, I've been out in the community talking to people about COVID symptoms, and I get a lot of confusion about the difference between flu symptoms and COVID symptoms. But it hasn't really occurred to me that a lot of the symptoms of acute HIV infection could overlap or masquerade as COVID. I haven't diagnosed anybody with acute HIV infection during the pandemic, but I think we all need to be thinking about that. Have you encountered this problem yet?
Yeah, I haven't encountered the problem as I've been out of clinical care, with the exception of doing some virtual or telemedicine visits since the beginning of the pandemic. I've been out of the clinical space, but I will say that I've heard some conversations starting around that. And so I think as we move forward, because I'm a firm believer that COVID-19, even with the vaccines that we have coming up, we don't know whether it's going to just go away and this is going to be a one-off, or whether it will linger around. And as a lot of the infectious disease and public health experts have suggested, that it possibly may be something that's more seasonal, like the flu, that we need
Let's
to
hope
re-up.
not.
I hope not too, but some people are suggesting that we don't know right now, so we need to be prepared for that. So I think it would behoove all of us as medical educators and medical providers to make sure we are aware and are training current providers and future providers to know that difference. And for me, the flu and COVID and acute HIV have some very similar, core things that happen. You could have myalgias, fatigue, fever. Those are kind of the three that we see. And when we think about the flu, and I definitely want you to add on what you've seen and what you've read about with these symptoms, but the flu kind of is, this whole body thing, and it doesn't involve having a rash. Where we usually make the
Yeah.
determination with acute HIV infection is that you can have a rash with that. And so it tends to be this rash that sometimes can look like an allergic reaction, but to be honest, could present as anything when we're seeing that. So I think one of the other things that comes up, and I've seen this with COVID-19, we think about the loss of taste and smell. We think about shortness of breath or coughing.
Yeah.
And also, too, not commonly cited, but does happen with the flu and acute HIV as well, is GI symptoms. So I've heard people with COVID-19 say, you know what, I didn't have any shortness of breath or myalgias, but I had diarrhea for several days. I've heard people with the flu say that not only with the shortness of breath and the fevers and the myalgias that they also had diarrhea. And then with acute HIV, we do know that you can get acute diarrhea from that as well. So I think it's important to have the antenna up so that when someone presents with this constellation of kind of vague symptoms or common symptoms, that we're checking the boxes and asking the right questions to determine what testing we need to follow.
Yeah, I think my biggest concern, I completely agree that the rash is the symptom that would differentiate the three of them. But I think my biggest concern about diagnosing acute HIV infection during the pandemic is there's so much telemedicine happening, and if it's not on the radar, people will not order the test to figure out if someone even has HIV to begin with, but certainly acute HIV infection, because I'm afraid what's taking up most of the bandwidth right now is COVID-19. And even the flu numbers are down predictably, though, so far because of the mask wearing and social distancing. So, I think, especially if people are listening to this conversation, I would just encourage people to really continue to think about the differential diagnosis of someone who comes in with these vague symptoms, because I shudder to think of how many people we might be missing now because we're only thinking about COVID.
Yeah, it's hard. And, being someone that's worked in student health as well, we didn't even talk about the symptom of sore throat, which can happen in acute HIV as well as mono. We didn't even mention mono, but mono you can add on that differential list, depending on the demographic or the time of year, can mimic all these symptoms as well. And so I think just on all of our behalf, we need to make sure that it's on the radar. And I think it'll be easy. And you're absolutely correct with the virtual medicine and the telemedicine. I think although it is a good technological breakthrough, I do pull back on the declaration that it's the future of medicine. I don't think virtual medicine and telemedicine is the future of medicine. I
I
think
agree.
it's a future option, but there are so many limitations to it. Not only, and people say, well, you could take a picture of a rash and then upload it, but cameras don't always display well. And, there's a lot of things you can't do. And people say, oh, well, you can have somebody, through the USB port, you can put the stethoscope on the heart and you can do that. It's just not going to be the same. And it's just one of those professions that you can't completely replace through telemedicine or through, a virtual substitution. I just don't think it's possible.
And it doesn't give you the texture either, particularly for rashes, right?
Right.
So I definitely like telemedicine as an adjunct or to augment, but I completely agree with you that it's not going to supplant the traditional provider relationship, which is good because we like seeing our patients.
I know we do, and our patients like seeing us. When I did some focus groups with some students at some of the campuses down here in Atlanta, they said when we brought up the topic of telemedicine, they were like, "No, I want you to touch me. I want you to see me." Like, and unless it was something that was mental health counseling, they were more inclined to, "No, I want you to actually see me." One of the other considerations that I thought, and I wanted to ask you about this, what do you think about resources for this? Because if we're asking providers to think about the flu, to think about mono or EBV, COVID-19, and acute HIV, are you seeing a lot of institutions and facilities that actually have the resources to do the kind of clear waved, on the spot testing that is required to make these diagnoses in the acute setting?
Oh no, I think people are really scrambling. If I use DC as an example, although LabCorp has really risen to the occasion and they're doing tons of testing, but the city has resorted to offering testing at fire departments.
Right.
There's another company that's come in and they're contracted just to do coronavirus testing. So no, I think we still have a long way to go. I think we're still missing a lot of people despite the surge in the numbers we're seeing. I mean, I think there's still a lot of undiagnosed cases out there. Just hopefully they are the cases that will resolve, with time, sort of the self-limited um, symptoms. But yeah, I think people are struggling. Institutions are struggling to keep up with the demand.
Yeah, and I'm hopeful too along that point that maybe administrators and directors and nurse managers will basically look at their budgets and their resources and kind of invest in having a stock of rapid flu tests or COVID-19 tests during a certain time of the year if we're seeing an uptick like around the fall. And obviously HIV, acute HIV doesn't have a season per se. So they need to have the rapid testing, the rapid antigen and antibody testing available to people as they come in. And particularly when we talk about acute HIV, I think not just having the antibody test, which may take a few months to test positive, because I've seen patients come in where they were going through acute retroviral syndrome for HIV and had a negative rapid antibody test. But then when we did the blood test later and did the fourth generation antigen antibody, that came back positive. But everyone said it was a student, so they were like, "Oh, that was probably mono." And then when we did the HIV testing, fourth generation, it came back positive. We realized it wasn't mono; it was actually HIV. So I think while we're doing rapid on the spot testing, we have to be updated with the latest technology and do the antigen antibody test rather than just the antibody test itself.